Welcome to this Step 2 clinical knowledge review on psychotic disorders test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for psychotic disorders and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the psychiatry and behavioral science sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize the high-yield question stems that the boards use for psychotic disorders. Second, we will apply specific test-taking strategies for schizophrenia, brief psychotic disorder, and schizoaffective disorder questions. Third, we will master the next best step question format for diagnosis and management of these conditions, including antipsychotic medications. Before we dive in, remember to review the psychiatry chapters in first aid and your question bank. This video is about strategy, not memorization. Let us get started. Our first strategy is what I call the psychosis duration split. This is the single most important framework for psychotic disorder questions on the boards. When you see a question stem describing psychotic symptoms, the very first thing you should do is check the timeline. If symptoms have been present for less than 1 month with full return to baseline, think brief psychotic disorder. If symptoms last between 1 and 6 months, that is schizophreniform disorder. And if symptoms have been present for 6 months or longer, that is schizophrenia. The boards test this distinction constantly. Duration is your best friend on these questions. Train yourself to look at the timeline before anything else. Our second strategy focuses on distinguishing positive versus negative symptoms. This matters because the boards will test which medications work best for each type. Positive symptoms are things that are added to the patient experience, like delusions, hallucinations, and disorganized speech. Auditory hallucinations are by far the most commonly tested type on the exam. Negative symptoms are things that are taken away, like flat affect, alogia, avolition, anhedonia, and social withdrawal. Here is the high-yield board pearl. Negative symptoms predict poorer long-term outcomes and respond less well to typical antipsychotics. When the question describes a patient with prominent negative symptoms, the boards want you to choose an atypical antipsychotic as the preferred treatment. Now let us talk about recognizing the classic question stems for each disorder. For schizophrenia, the stem will describe a young adult, usually in their 20s, with auditory hallucinations, paranoid delusions, and functional decline lasting more than 6 months. They will often mention that the patient has stopped going to work or school. For brief psychotic disorder, look for sudden onset after an identifiable stressor with symptoms lasting less than 1 month. The key phrase is full return to pre-morbid functioning. For schizoaffective disorder, the stem will describe psychotic symptoms overlapping with mood episodes, but the critical detail is that delusions or hallucinations persist for at least 2 weeks without any mood symptoms. That 2-week independent psychosis period is the make or break detail on these questions. Let us work through our first practice question. A 24-year-old man is brought in by his family for increasingly bizarre behavior over the past 8 months. He believes the government is monitoring his thoughts and hears voices commenting on his actions. He has stopped attending college and stays in his room. His urine drug screen is negative. What is the most likely diagnosis? Take a moment and think about which answer you would choose. The options are A. Brief psychotic disorder, B. Schizophreniform disorder, C. Schizophrenia, D. Schizoaffective disorder. Let us walk through this answer step by step. Step 1. Spot the pattern. We have a young male with paranoid delusions, auditory hallucinations, functional decline over 8 months, and a negative drug screen. Step 2. Apply the rule. The 8-month duration exceeds the 6-month threshold. The negative drug screen rules out substance-induced psychosis, which is a classic board distractor. Step 3. Eliminate wrong answers. A. Brief psychotic disorder requires symptoms lasting less than 1 month, so that is out. B. Schizophreniform disorder only applies between 1 and 6 months. D. Schizoaffective disorder requires concurrent mood episodes, which are not described here. The answer is C. Schizophrenia. Remember, always check the timeline first and always rule out substances. Here is our second practice question. A 32-year-old woman with no psychiatric history presents with acute onset of paranoid delusions and disorganized speech 3 days after the unexpected death of her child. Her symptoms began 5 days ago. She has no history of mood episodes. What is the most likely diagnosis? Think about the key features in this stem before choosing your answer. The options are A. Schizophrenia, B. Schizophreniform disorder, C. Brief psychotic disorder, D. Acute stress disorder. Let us break this one down. Read the question carefully. We have sudden onset psychotic symptoms lasting 5 days with a clear precipitating stressor and no prior psychiatric history. Now, why does brief psychotic disorder win here? Schizophrenia requires 6 months of total disturbance, so we can eliminate A immediately. Schizophreniform disorder requires at least 1 month, but our patient has only had symptoms for 5 days, so B is out. Acute stress disorder presents with dissociation, re-experiencing, and avoidance, not frank psychosis, with delusions and disorganized speech, so D is eliminated. Brief psychotic disorder is defined by at least 1 day but less than 1 month of psychotic symptoms, with eventual full return to baseline. The identifiable stressor is a classic board clue. The answer is C, brief psychotic disorder. Now let us cover antipsychotic medications, which are heavily tested on the boards. First-generation or typical antipsychotics like haloperidol and chlorpromazine primarily block dopamine receptors. They are effective for positive symptoms but carry a high risk of extrapyramidal symptoms and tardive dyskinesia. The boards absolutely love testing Neuroleptic Malignant Syndrome, which presents with fever, rigidity, elevated creatine kinase, and altered mental status. This is a medical emergency. Second-generation or atypical antipsychotics like risperidone, olanzapine, quetiapine, and aripiprazole are preferred as first-line treatment. They carry lower risk of movement side effects but higher risk of metabolic syndrome, including weight gain, diabetes, and high cholesterol. The special case is clozapine, which is reserved for treatment-resistant schizophrenia and requires regular blood monitoring for the potentially fatal side effect of agranulocytosis. Here is our third practice question. A 28-year-old woman presents with a 2-year history of auditory hallucinations and persecutory delusions. During this time, she has had multiple episodes of depressed mood lasting several months each. Notably, her hallucinations and delusions have persisted for 3 weeks during a period when her mood was stable. What is the most likely diagnosis? The options are A. Major depressive disorder with psychotic features, B. Schizoaffective disorder, C. Schizophrenia, D. Bipolar disorder with psychotic features. Let us walk through this answer. Spot the classic pattern. The patient has both psychotic and mood symptoms over a 2-year period. The critical clue is that psychotic symptoms persisted for 3 weeks without mood symptoms. This independent psychotic period is what distinguishes schizoaffective disorder from a primary mood disorder with psychotic features. Here is the key distinction. In major depressive disorder with psychotic features, the psychosis only occurs during mood episodes. Same for bipolar disorder with psychotic features. In schizophrenia, you would not see the prominent mood component described here. Schizoaffective disorder uniquely combines both features with independent psychosis. The answer is B, schizoaffective disorder. For your boards, always look for that 2-week period of psychosis without mood symptoms. Here is a critical test-taking pearl on antipsychotic side effects. The boards frequently present a patient on an antipsychotic who develops a new side effect, then ask you to identify the offending agent or choose the best alternative. Here are the high-yield pairings you need to know. Haloperidol is associated with extrapyramidal symptoms and tardive dyskinesia. Olanzapine and clozapine cause significant weight gain and metabolic syndrome. Quetiapine is the most sedating. Risperidone causes hyperprolactinemia, which can present as galactorrhea or amenorrhea. Ziprasidone prolongs the corrected QT interval. And clozapine requires regular complete blood count monitoring for agranulocytosis. When you see a side effect in the question stem, match it to the drug. When asked to switch medications, choose the one with the lowest risk of the problematic side effect. Know that Neuroleptic Malignant Syndrome is a medical emergency treated with dantrolene and bromocriptine. That wraps up our review of psychotic disorders test-taking strategies for Step 2. Remember, the 3 key strategies are: first, always check the duration to differentiate between brief psychotic disorder, schizophreniform disorder, and schizophrenia. Second, look for independent psychosis without mood symptoms to identify schizoaffective disorder. Third, match antipsychotic side effects to the specific medication. For deeper study, review the psychiatry and behavioral science chapters in first aid and work through related questions in your question bank. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe to our channel for more board review content. Good luck on your exam.